Yeah, good afternoon, everyone. My name is Michael Zimmermann, and I'm a professor of human nutrition at the Swiss Federal Institute of Technology in Zurich, Switzerland. I'm also the chair of the Iodine Global Network. And it's a great pleasure to be able to present at this webinar. I would like to thank Dr. Renuka for inviting me to speak about sustaining salt iodization programs in compatibility to salt reduction. Now, as you've just heard, iodine deficiency remains a major global health problem. Iodine deficiency disorders for many years have been one of the most common human diseases and one of the most common causes of preventable mental retardation around the world. Fortunately, we have a simple, inexpensive, and sustainable way to eliminate iodine deficiency, and that is through salt iodization. Now, the key points of my presentation today are going to be that using salt as a fortification vehicle in poor areas of rural subsistence farming in Africa and Asia is not only an effective choice, but it's often the only choice. And this is particularly true in key regions such as Sub-Saharan Africa and South Asia, where the health and economic burden of iodine deficiency disorders is the highest. So let's look at these two key points. Now, we know that salt is the preferred vehicle in most places for the delivery of iodine based on several factors. It's one of few commodities which is consumed by everyone. Consumption levels are fairly stable throughout the year. Its importation and production in many countries is limited to just a few producers. Iodization technology is easy to implement and is available at a reasonable cost, even in the developing world. The addition of iodine to salt or iodized salt to processed foods does not affect the color, taste, or odor of foods. And finally, the quality of iodized salt at the production level or at the household level can be easily monitored. So these are many benefits of using salt as a vehicle for delivery of iodine. Now, in rice-eating populations of Southeast Asia, in the 1990s, USAID looked at potential fortification vehicles in poor urban and rural areas of Indonesia. And they found that salt and monosodium glutamate was consumed daily in more than 90% of households, and consumption of these condiments was not associated with socioeconomic status. This was a survey done in 4,000 households. For all other processed foods, consumption was less than 80% at the household level and was strongly associated with socioeconomic status and was lowest among the poor. So the conclusions of this study were that salt and MSG were really the only suitable vehicles for fortification to reach the poor in Indonesia and other rice staple regions of South Asia. Now, similarly, in areas of rural West and Central Africa, most food is locally produced and processed on small subsistence level farming. A study showed that in 3 rural areas of Côte d'Ivoire, with different staples, yam, cassava, and rice, dietary records indicated that habitual salt consumption was about 6 to 7 grams per day for adults and 3 to 5 grams per day for children. It was found in this study that only salt and bouillon cubes were purchased by more than 90% of households, and purchase of salt was independent of socioeconomic status. The next best potential vehicle in this setting would have been palm oil, but it was only purchased regularly by less than 50% of households. So in areas like this of subsistence farming in rural West Africa, salt is really the only vehicle that can be used to provide salt to populations. Now, it's important that we provide iodized salt in these areas, such as South Asia and Sub-Saharan Africa, because most of the DALYS lost due to iodine deficiency are in regions of Africa and Asia where salt is really the only fortification vehicle able to reach many of the rural poor. And here you see data from the World Bank showing you that about 50% of DALYS lost due to iodine deficiency occur in South Asia and sub-Saharan Africa. Now, the use of iodized salt is also of great appeal because it has a remarkably high cost effectiveness. For example, on the left, you can see a table from the World Bank, which shows you the cost per child covered and the cost per daily averted of iodized salt versus other common nutritional interventions like iron fortification or zinc supplementation. You can see that iodized salt is more than double as cost effective than iron fortification of foods or providing zinc supplements. The cost per daily averted was $34 to $36 US. Now, for example, in the West African region, the World Food Fortification Guidelines also estimated the cost-benefit ratio of iodized salt. So in West Africa, with the assumptions being that the annual per capita GNP was $430 US, the wage share of GNP was 40%, the goiter rate was 15%, and births to women with goiter had an average productivity loss of 11%. So in this scenario, if the cost of iodized salt is about 10 US cents per person per year, the benefit cost ratio is a remarkable 26.5 to 1. And if we can reduce the cost of iodized salt as low as 1 cent per person per year, as is the case, for example, in Central and South America, the benefit cost ratio skyrockets to 265 to 1. So clearly, iodized salt is a remarkably high cost-effective program. Another way of looking at this was analyzed by Sue Horton, where she looked at the estimated annual potential costs attributable to iodine deficiency in the developing world, which she estimated to be nearly $36 billion per year lost prior to widespread salt iodization versus 0.5 billion per year lost of a cost for salt iodization. So she estimated about a 7-to-1 benefit to cost ratio. And the Child Steering Group in the Lancet has emphasized that salt iodization remains the most cost-effective way to deliver iodine and improve cognition in children. Now, we also know that dietary sodium reduction is a major public health priority. Here you see the WHO guidelines about recommendations for salt intake reduction for the prevention of non-communicable diseases. And the recommendations are for consumption of adults to be less than 5 grams of salt per day. Now, the question is, of course, as salt intakes fall in an effort to reduce blood pressure and cardiovascular disease, can we maintain sufficient iodine intakes in population if our main delivery vehicle for iodine is salt? Now, the WHO has said that policies for salt iodization and reduction of salt to less than 5 grams per day are compatible, cost-effective, and of great public health benefit. However, countries will need to periodically adjust their levels of iodine fortification as salt intakes fall. Now, in a perfect world with true universal salt iodization, where all salt that's consumed was iodized, it would be simple for national programs to titrate iodization levels as salt intakes rise or fall. An example of this is in Croatia, which has an exemplary iodized salt program. All food salt at 3 plants and at import is iodized. So this is true universal salt iodization. Now, based on estimated daily per capita salt intakes of 10 grams currently, the Croatian program iodizes all salt, both for the food industry and in households, at 25 ppm. And this provides theoretically 250 micrograms per day. And this is what you see when you look at the urinary iodine concentrations, which are our biomarker of iodine intake. And the median urinary iodine concentration in school-age children is 248 micrograms per liter, and in pregnant women is 159 micrograms per liter, both in the normal and sufficient range. Now, for example, in Croatia, if we were able to achieve salt reduction to a level of 5 grams per day, salt iodization could be increased to 50 ppm without technical or sensory barriers. And this would again ensure intakes of 250 micrograms per day at the reduced salt intake of 5 grams per day. So this is a fairly straightforward way of looking at improving salt iodization in the face of salt intake reduction. Now, in the real world, it's going to be more complicated. The potential impact of salt reduction on iodine intakes, I think, will vary and will likely be very much country and context specific. I think it'll depend on interactions of several factors, including what are the baseline salt intakes in the country and how much salt intakes are reduced, whether reductions in salt intake occur mainly in households versus industry. The extent of household coverage with iodized salt will play a role, and the extent of the use of iodized salt by food industry will play a key role. Also, the relative contribution of household versus food industry salt to iodine intakes. And finally, also the hidden contribution of dietary iodine sources, such as dairy products and groundwater. So all of these factors will interact when we look at the potential impact of salt reduction on iodine intakes in different settings. So I'd like to look at 2 examples now of South Africa and the Netherlands. Now, this nice study in 2012 showed that in urban South Africans with salt intakes even less than 5 grams per day, they have iodine sufficient intakes based on measuring the median urinary iodine concentration. So in this study, they collected 3 24-hour urine samples to measure sodium, and they measured a spot urinary iodine concentration in 262 adults. Now, the median urinary iodine concentration was 120 micrograms per liter in the sufficient range. And in this population, 23% of adults had salt intakes less than 5 grams per day, 51% had intakes 5 to 9 grams per day, and 23% had intakes greater than 9 grams per day. And you can see in the figure that at different categories of 24-hour urinary sodium excretion, less than 90, 90 to 150, and 150, that the median mUIC remained in the normal range in these 3 different subpopulations. And there was no association between the median urinary sodium concentration and the median urinary iodine concentration in this population. So this suggested that at least in this population, salt intakes could be reduced to less than 5 grams per day, and urinary iodine concentrations would remain in the normal range. What about a country like the Netherlands? Now, this study in 2010 used the Dutch food intake data and updated food composition data to estimate habitual salt and iodine intake. Now, to account for uncertainty about iodized salt use, both industrial use and discretionary household use, they used a simulation model. And habitual iodine and salt intakes were simulated for different scenarios of salt reduction compared with no salt reduction. Now, this figure shows you the simulated models. We look at 3 different population groups: children 4 to 6 years of age, girls 11 to 14 years of age, and women older than 18 years. Now, you can see in the orange box the estimated average requirement for iodine for these 3 groups. And then you can see the intakes at current intake of salt, which are the pale blue boxes. Then at 25% salt reduction in processed foods, the medium blue boxes, and then finally 50% salt reduction in processed foods and in household salt intake. And those are the lowest, darker blue bars. And you can see that In this simulation, intakes close to the estimated average requirement only occurred when there was a 50% salt reduction in both processed foods and in household intakes. So in this study, at least, this is of course a simulated model, but this suggested that only when we could achieve a 50% reduction in salt intake across the board would habitual iodine intakes less than the estimated average requirement slightly increase to within the 1 to 10% range. So the projected effects of sodium reduction on Dutch iodine intake, in this study at least, was that salt reduction of 12, 25, or 50% in industrial processed foods resulted in a mean 6, 12, or 25% reduction in iodine intake. And the 5th percentile of iodine intake remained near or above the estimated average requirement for most age groups. Now, the WHO expert consultation on salt as a vehicle for fortification in 2007 stated that at the country level, close collaboration between salt iodization and salt reduction programs is urgently required so that their aims are congruent. So I think my key points now are that policies for salt iodization and reduction of salt intake are compatible. However, impact on iodine intakes of salt reduction will be highly context and country specific. And because of this diversity, a generalized iodization standard probably will be of only limited value as salt intakes fall. And I think as we reduce salt intakes in the population, it's going to become more and more important to carefully monitor iodine status using urinary iodine concentrations and tailor the iodine content in iodized salt in order to maintain adequate intakes in the population. So with that, I'd like to finish my presentation. And again, thank you very much for allowing me to participate in this webinar today.